Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will start our short videos. It will be about 6 to 7 minutes maximum to understand clinical short cases. We will start by station 1, which is respiratory. We will know how to examine a patient with in station 1 chest case. We will know how to present the case. Also, we will take a general view on the investigation and the treatment. First of all, in examination, you will enter the room, greeting the patient and the examiner, go to the wall and wash your hand. Then start by general survey about 30 seconds, looking for any clue. Then start by the hand. Any clue like sputum bot, oxygen cylinder, tissues also may indicate there is productive cough. Go to the hand for 4C, clubbing, cyanosis, cigarette, which is tar staining, CO2 retention, which is flapping tremor. Also fine tremor indicates the patient is using beta-2 agonist. Palm for palmar erythema and respiratory rate while you are pretending that you are counting the pulse. Then go up in the head and neck for raised GVB, which is indicate pulmonary hypertension, pallor or jaundice. Check for the mouth under the tongue for central cyanosis. Then inspect the chest for scar or deformity. This is very important. Go to the end of the bed at patient leg. At the patient leg, ask the patient to take a deep breath to check for asymmetry. And can you give me a cough, please? If it's dry, you are dealing with pulmonary fibrosis. If it's wet, you are dealing with, productive, you are dealing with bronchiectasis. In front of the patient, important to try to palpate the apex. If not felt, try to check it by stethoscope. If it's not felt, try to palpate it in the right side, which indicate or suspect Cartagena syndrome, which is a common case in chest, which is usually associated with bronchiectasis. Check for loud B2 and raised parasternal heave, which is a sign of pulmonary hypertension. Chest expansion in 3 areas in the front, supramammary, mammary, and inframammary. Take a fold of the skin and notice your thumb, movement of the thumb. Reduced movement, there will be limited expansion. Percussion in 5 areas, supraclavicular, clavicular, supramammary and inframammary, and also inside the axilla, in the mid-axillary line. Auscultation for breathing sound, added sound, or vocal resonance by asking the patient to say 9-9. Then ask the patient to sit. You have to examine the trachea, very important. Check if it's central or deviated, can give you a very important information about the site of lesion. If there is any effusion, it will be shifted to the other side. If there is collapse, it will be pulled. If there is also pneumonectomy, can be pulled to the same side of the scar. Cardiac sternal notch and tracheal tug for COPD, and examine for lymph node, at least supraclavicular lymph node. Back for the same, chest expansion, percussion, suprascapular, interscapular, and infrascapular, and auscultation. Lastly, lower limb for edema, cover the patient and thank him. How to present a chest case, very important. You have to comment on presence of scar, deformity, CHABA, and 3C. Inspect for scar and deformity, CHABA, chest expansion, comment on percussion, on auscultation, and 3C, which are cause. If you find any cause, for example, patient has pulmonary fibrosis secondary to systemic sclerosis or rheumatoid arthritis, complication as pulmonary hypertension, cor pulmonale, respiratory failure. And I want to complete my examination by checking for saturation, peak expiratory flow meter, and sputum examination, and taking history about smoking and so on. I gave you example for case presentation. I have examined this gentleman who is lying comfortable in bed. By inspection, there is no scar or deformity. There is clubbing in his fingers. Respiratory rate 16 cycle per minute. Trachea is central. Chest expansion is equal bilateral but reduced. Percussion, there is dullness on both sides bibasally. By auscultation, there is fine end inspiratory crackle which does not change with cough. There is no complications. I could not appreciate the cause. I want to complete my examination by checking saturation and so on. Putting all together, my top of differential is idiopathic pulmonary fibrosis. Investigation of a chest case mostly the same. You will do basic investigation like CBC. Of value, white blood cells if high indicate leukocytosis, there is infection. If secondary polycythemia indicate chronic hypoxemia. Inflammatory marker like ESR, CRP, renal function test, liver function test of value in case of alpha-1 antitrypsin deficiency, it will be elevated. Investigation to confirm diagnosis, majority of chest cases there will be chest X-ray, high resolution CT, sputum culture and sensitivity, especially if you suspect infection like suppurative lung syndrome, bronchiectasis, lung abscess, sputum acid fast bacilli culture or PCR, this is for TB case, and the pulmonary function test measuring forced expiratory volume 1 compared to forced vital capacity more than 70, it will be restrictive, less than 70, it will be obstructive. Restrictive like pulmonary fibrosis, obstructive like COPD. Investigation for the cause, as we mentioned before, search for the cause. Patient has pulmonary fibrosis, there is manifestation in his hand of rheumatoid arthritis. Patient, we will do anti-CCP and so on. Patient has bronchiectasis, search for causes for HIV. Investigation for complication, the majority of chest cases will end in the same complication. A respiratory failure, so we'll do ABG if it's type 1 like pulmonary fibrosis, type 2 like COPD or bronchiectasis which is hypoxic hypercapnic. Majority of chest cases also complicated will be by pulmonary hypertension and cor-pulmonale, so you will do ECG and echo. Lastly, treatment of a chest case also mostly is the same, non-pharma and pharma. Non-pharma, keep it in your mind like your name: patient education, patient counseling, stop smoking, vaccination against Haemophilus influenza, pneumococcus, COVID and influenza, pulmonary rehabilitation program, support like social, financial, occupational, psychological and so on. Pharmacological, majority of chest cases will take antibiotic, inhaler, mucolytic, bronchodilator and long-term oxygen therapy, and there will be some indication, and surgery in the form of either lobectomy, pneumonectomy, lung volume reduction surgery, bulloctomy, and at the end there will be lung transplant. So today we finish our chest station 1 respiratory. We will do more videos about this every case in details, but this video for general view for station 1 respiratory, as the majority of chest case share the same investigation and the same treatment. Thank you very much, and we will meet soon inshallah. Assalamu alaikum wa rahmatullah.